healthcare-associated pneumonia. This is a 64 years old male patient with a past medical history of COPD, presented to the ER with 1 week long shortness of breath. He stated that his shortness of breath has been progressively worsened since being discharged home from hospital on 10/29th, 2013, which was 1 month ago. Only moderate relieved by rest. Other associated symptoms including nausea, lower grade fevers, pleuritic chest pain with a cough on the right side, and white sputum production. He also has a history of obstructive sleep apnea and has been compliant with his CPAP at home. Upon admission to the ER today, patient was placed on BiPAP and given IV Lasix 40 mg times 1. He also received antibiotics treatment of topramycin, vancomycin, and zosyn. Past medical history: hyperlipidemia, diabetes mellitus, hypertension, obstructive sleep apnea, gastroesophageal reflux disease, angina pectoris, coronary artery disease, esophagus, Barrett esophagus, and depression. He has numerous coronary artery bypass graft and angioplasty in the past. He is a smoker, a former smoker, and smoked up till 2009 with a history of 1 pack for 40 years, denies alcohol and recreational drug use. He has been on medication for hypertension, antidepressant, anti-lipid, diuretic, insulin, and GERD. Physical assessment: blood pressure 128/55, pulse 78, respiration 26, and the BMI is 38.27. And he is currently on BiPAP, and his oxygen saturation set at 100%. No JVD, however, scant crackles bilaterally, mild respiratory accessory muscles use noted. Abdomen, extremity, and neural are benign. Lab revealed leukocytosis, mild anemia, and his BNP, brain natriuretic peptide, is 537, and his sodium is 132, and the creatinine is 0.83, which the kidney function is okay other than hyponatremia. Cardiac enzymes is negative. Chest x-ray revealed bilateral airway disease, suggesting either the acute pulmonary edema or pneumonia. And his echocardiogram showed ejection fractions 65%, so there is no systolic ejection fraction decreased. Based on subjective and objective data, and we already reviewed pneumonia. Patient is admitted with a pneumonia, and sometimes X-ray can be very vague. So this is a time patient will be treated for hospital associated, healthcare associated pneumonia because of increased WBC, tachypnea, oxygen saturation decreased, and recent history of pneumonia. Without treated pneumonia, patient can develop SARS or septic shock and sepsis. The worst complication can be ARDS. Assessment. With this patient, the first assessment will be acute respiratory insufficiency because patient presented with the hypoxia and currently require BiPAP treatment. Possible healthcare associated pneumonia with a history of OSA and then CPAP since he's already on the BiPAP treatment. Is there's a pulmonary edema with the brain natriuretic peptide elevated? Maybe there is. However, pneumonia should be treated for this patient. We use a concept map for our student to really summarize the assessment. The assessment basically is based on subjective and objective data, and concept map we usually use three most prominent concepts for this admission, for this current admission. So for this patient, the most important one here I summarized based on the all the past medical history and the subjective and objective data. We say pneumonia associated with shortness of breath and cough and hypoxia. How others contributed this when students put this concept map together, they have to make the connection between one concept to the next one with their relationship in pathophysiology or pharmacology. And for example, obesity-related obstructive sleep apnea can be associated with hypoxia, and GERD with aspirational pneumonia, or with anybody have a GERD, they have a high tendency of micro aspirate bacteria into their lungs, causing pneumonia. Pneumonia is inflammatory response of the parenchyma of the lungs. When pneumonia occurs, the bronchi and the alveolar filled up with the white blood cells, red blood cells, and fibrin. Remember, parenchyma of the lungs is the area oxygen and the CO2 exchange occur. So, with pneumonia, the fluid inside the alveoli, it's natural to think that they will have a shortness of breath, and those cumulative white blood cell, red blood cells, or we call it a sputum, has to come up. So cough is also very natural. However, hypoxia depends on the extensiveness of the alveoli involved. If it's a diffused, all parenchyma of the lung involved, then the hypoxia is not able to be corrected by increased oxygen concentration. So this usually treated with mechanic ventilator support. How others related to pneumonia? Recent pneumonia certainly can contribute current pneumonia. With the COPD, the mucociliary function impaired, especially with a patient have a past history of a smoker, so they can have a decreased cleaning function for the bronchi. Also, with the diabetes, patient can have a decreased immune system. Remember, immune system is the most important defensive mechanism to prevent pneumonia from happening. So if immune system is decreased, then bacteria enter into the lung. The defense system will not be able to eliminate them. Therefore, they're causing alveoli filled up with white blood cells and red blood cells of fibrin. To this, I put all these concepts together and to give you an idea how you will provide a nursing care. With this patient for pneumonia, of course, antibiotics treatment with Zosyn, vancomycin, and topramycin. It covers its broad spectrum antibiotics. Topramycin will cover healthcare associated pneumonia such as Pseudomonas. Vancomycin is super antibiotics for gram-positive bacteria and Zosyn for gram-negative. However, with broad spectrum antibiotics treatment, you need to worry about normal flora and diarrhea, C. diff as complication. Other pneumonia complications including SIRS, systemic inflammatory response syndrome. Usually when patients have this response, they will have elevated temperature, tachypnea, tachycardia, and leukocytosis. The difference between SIRS and sepsis is sepsis will have bacteria grow in the culture, and hypotension with SIRS and sepsis usually requires pressor and ICU stay. And if it's ARDS, that means that the lung tissue will not be able to exchange CO2 and O2, therefore patient have a acute respiratory failure require mechanical ventilator support. With hypoxia, as we said, the degree of the oxygens, nasal cannula, um, ventimask, non-rebreather, 100% of course non-rebreather, and the BiPAP to mechanical ventilator support. With the cough, expectorant is encouraged. However, cough suppressant is discouraged because you want them cough up the sputum instead of letting the sputum become bacteria medium. With the other nursing care management, including here the immune system, the vaccination, the sitting up while eating decrease aspiration of pneumonia, and continuously use CPAP if a patient is not on BiPAP or mechanical ventilator. So you can see that the concept map we developed focused on problems, and the problems will guide us to the nursing care and the treatment. Thank you. I also have another concept map here to show you that if a patient also have a cough and hypoxia, however they come in with a focus problem instead of pneumonia is heart failure and acute pulmonary edema, therefore the care for this patient is different. The focus will be from heart failure, strict ano monitoring, coronary artery disease management. With acute pulmonary edema will be diuresis, Foley catheter. With a cough, expectorant and cough suppressants can be utilized. Hypoxia, same as we mentioned before, and nursing management to control the contributing factors will be depending on what other contributing factors, especially with the patient have a history of atrial fibrillation, and with atrial fibrillation it's a very common precipitator to the heart failure because the heart needs that atrial kick to have the blood return to the heart. And with the heart failure patient, you will need to control atrial fibrillation, so you need to monitor patients' rhythm, heart rhythm, what's going on there. Okay, and that's it. Thank you.